It's a treat on the Hem-Onc Pulse today. Dr. Elias Jabbour from MD Anderson Cancer Center is with us to simplify what I believe, Ellie, is a pretty complex topic, or you guys have made it too complex, or you're too simplistic. So it's acute lymphoblastic leukemia. And the reason I wanted to talk to you about this, because there's a lot of things going on when treating pH positive, pH negative, chemotherapy regimen with chemotherapy, and MRD. I mean, so many things happening in ALL. But at the same time, also, there's a lot of patients with ALL who are being treated in a community setting for a variety of reasons. And I think we want to make sure we clarify how to best approach these patients. So I appreciate you taking the time, and maybe a little bit of an introduction for folks who probably don't know what you do every day, day in and day out.
Chadi, thank you for having me on your podcast today. It's a pleasure to be here, especially in this time where we're discussing ALL, and share with you the novelties and the progress and the optimism about curing this disease. So my name is Elias Jabbour. I work at MD Anderson in Houston, Texas, and I'm in charge of the ALL program in my department. And I had the privilege to work with Dr. Katarjan and big leaders here in my institution with vision, where we aim to improve the cure rate of this disease in adult to the level seen in pediatrics. So ALL today had by two peaks. One in the pediatric setting, highly curable, 90% cure rate. And the second one is an adult patient, including with age. Unfortunately, we don't have the cure rate seen in pediatric. And the idea was why we cannot get to this level. Well, two reasons historically were. Number one, the pediatric disease is more benign as a biology. Number two is the children have better tolerance to chemotherapy than adult patients, and mainly older patients, where you give them any chemotherapy, you can break them with your chemotherapy. Then we had the discovery of target therapy. And I will quote here two main drugs. The tyrosine kinase inhibitors in ALL Philadelphia positive, which is more common in adult compared to pediatric. And the second, the immune therapy approach or platform, starting with the antibody drug conjugate and bispecific engagers and then the CAR T cells. And these were revolutionary in the treatment of ALL. And I want to show you some of the data we have today, reaching the level of pediatric ALL patients. I want to start with different subsets.
But before we get there, I want us, as you think about simplifying this for us, I want to make sure we talk about the Philadelphia chromosome negative disease and then the Philadelphia chromosome positive disease.
Okay.
Which one do you prefer to start with? Because I think
let me start with the Philadelphia positive ALL.
Okay, so this is the one that you would use tyrosine kinase inhibitors.
Correct. So historically, this patient had a very poor outcome. If you have ALL Philadelphia positive, survival at 1 year is only 10%. Patient will get transplant, will relapse, and die. Then we have the tyrosine kinase inhibitor. Starting with the first generation, second generation, we improved the outcome with or without transplantation to a level of 40%. I mean, 60% are still dying from their disease, which is really unfortunate. Then we said, why we're relapsing? We're relapsing because we don't have a deep molecular response. And second, we have relapses driven by the acquisition of a mutation called T359 that can prevent the binding of the tyrosine kinase inhibitors in the protein. And therefore, we moved into a third generation of tyrosine kinase inhibitors that can deepen the responses and overcome the problem of the resistance. So first, we combined the chemotherapy plus ponatinib. This is the TKI. And we've shown at 5-6 years having a survival of 75%. And while transplant was the only way to cure this patient, we showed for the first time that we may not need a transplant to be offered to this patient. So it's practice changing.
So but as you said, why ponatinib? Why ponatinib?
Because ponatinib is more potent, so it does deepen the responses more. And two, and the most important element is it does overcome the problem of resistance, means it can suppress the emergence of mutations such as T359. It's very potent inhibitor that can suppress most of the mutations, and that caused the resistance in the previous generation of TKI. That's why ponatinib rationally was a good fit.
So you use chemotherapy, intensifies chemotherapy plus ponatinib.
Correct. No, you asked me at the beginning that in a community that may not be the case, which is true, because hyper-CVAD can be intensive and can be toxic and need some expertise, and you cannot do it left and right. So you need centers with expertise, centers of excellence. So before we move forward, we decided which TKI is the best, ponatinib or other TKIs. We did run a randomized trial called FACP trial comparing ponatinib to other TKIs, to imatinib, and we've shown that ponatinib is superior. So now we're expecting an approval of this drug hopefully soon, and the paper is being reviewed in JAMA for this matter. So the study is positive, met its primary endpoint, and we expect the drug to be approved, and therefore the question of the best TKI is solved today for the first time in ALL. But then people may think it's intensive chemotherapy, may not be palatable, let's do something different.
So
So
there are folks though out there that will tell you, why not do Gleevec, the first generation, and reserve the second and third generation for folks who don't respond to it because they feel that it's cheaper, there's maybe an opportunity that you don't want to really go all the way with the ponatinib. Is there a merit to trying the older generation at all?
I cannot discuss prices because, of course, I agree with the point of the prices, but in acute leukemia, you don't have multiple chances. I mean, I will not wait for the relapse. I want to take my drug up front. I want to induce the deepest response possible, spare it for transplantation, and cure my patient. If you're going to go for subsequent roads and get into transplant subsequent and others, possibly you can get there, but at a huge price of complication, morbidities, and others. Therefore, I think in acute leukemia, you're best. That being said, let me finish my thought, and I will go back to you. So the intensive chemotherapy may not be the most convenient way to do it. We know that immunotherapy, and in particular blinatumomab, have shown activity in RAP-affected ALL Philadelphia positive. Then the question was, well, can we, if blina is better than chemotherapy, superior, in a randomized trial, in a phase 2 trial, then if we combine the blina and TKI, we can deepen the responses, spare the need for intensive chemotherapy and complication, and cure these patients. So then what we did, we combined ponatinib and a blinatumomab combination, no chemotherapy, just simple treatment. And we did treat patients, more than 60 patients, with blinatumomab and ponatinib. We had shown a response rate of almost 80-90%, and a survival at 3 years today of 90%, and no need for transplant or intensive chemotherapy. And this can be done anywhere else.
You don't need consolidation for these folks?
Nope. We induce a deep response. What we're doing right now is we do ponatinib and blinatumomab. We have, after one cycle of treatment, around 70-80% response rate. We deepen the responses. We follow them by NGS. We give 5 courses of blinatumomab, and we monitor them by NGS for MRD. And if you're MRD negative, you're done. So it's a very simple treatment that can be done anywhere else in the world. It's not like for intensive chemotherapy and big institution. Just anybody can do that.
How long do you have to give how long do you give the treatment for?
6 to 7 months.
Okay.
Instead of lifetime.
And then if it's MRD positive, you continue?
No, essentially 90% get to MRD negativity within 3 months. Okay? So if you are MRD negative, you do 5-6 months of treatment and you're done, and you keep the ponatinib pills for maybe 5 years. We do not know how long. And if you're MRD positive, despite this, you can go for transplant or even CAR T cells. We're doing CAR T cells in Houston today. Very safe, very effective, very simple, can be done in a community or anywhere else. And a survival of a 90%. So we went from 10% survival to chemotherapy-free for the vast majority. I won't say curing everybody, but 90% MRD negativity and survival at 3-4 years. This is unheard of.
So this today in 2024, for patients with pH positive disease, using ponatinib plus blinatumomab, and you are not giving chemotherapy anymore.
I'm giving only intrathecal chemotherapy.
Intrathecal.
To prevent CNS relapse, we have 15. No, we have patients who have a very high risk, meaning white count of 75,000. Picardition plus. These patients may still need chemotherapy, and we do not know, but this is a possibility.
Is there a plan to randomize blina plus ponatinib to chemotherapy plus ponatinib?
No, the Italian are randomizing patient blina ponatinib to chemotherapy, low dose, and imatinib.
Okay.
The problem with this randomization is blina ponatinib is a 90% success rate compared to 20%. It's hard for me to randomize patients where I know that the results are so impressive. 90% survival compared to 20%. It's insane.
Yeah. Okay. So anything else for pH positive before we move on to pH negative?
I think small subset may still need some chemotherapy and transplant, but that remains to be seen. I think the future is now just twofold. Number one, to make sure we don't have relapses in CNS. Number two is, can we stop TKI? So we went from transplant to chemotherapy and TKI to chemotherapy free, but if we don't go for transplant, we need to give TKI for lifetime. And the question is, can we, like we do in CML, do 5 years of therapy and stop? And that is being evaluated right now at my institution and elsewhere.
That's amazing. Okay. I still have just a couple of questions for pH positive, but let's cover pH negative first to make sure. Because now you cannot use the TKIs.
No, in the pH negative, the discovery was, and the improvement was, historically we had a survival of 60% with the best chemotherapy, whether it's a pediatric regimen on hyper-CVAD, 60% cure rate. Then what we did, we integrated immunotherapy up front. We said, well, why I want to wait for the relapse till I go for salvage? We know that the outcome is driven by deepening the response. Blinatumomab, for example, have shown high efficacy in patients with a minimal disease compared to full disease. The question was, well, can we take this drug upfront? We designed a hyper-CVAD and we added blina to it. And we shortened the chemotherapy from 8 cycles to 4, and the maintenance from 30 months to 12 course of maintenance. So we shortened the chemotherapy and we added blinatumomab. We did this, okay? And we had the responses of universal response rate, MRD negativity around 80%. But then we had so far shown that such a combination can induce an MRD negativity by NGS of at 80% and a survival at 4 years of 80, 85% or 90%, which is amazing because historically the survival was only around 60%, and now we're at 90% survival without going for intensive chemotherapy while sparing chemotherapy. So essentially integration of immunotherapy up front, spare the need for intensive chemotherapy, and improve the outcome. This was done at Anderson first, and then we had a randomized trial sponsored by the ECOG 1910 trial, where patients were randomized to chemotherapy and blina versus chemotherapy alone, blina in MRD negative situation, and this study have shown that adding a blina up front improved overall survival.
Okay.
Which is amazing. So today we have a proof that blina upfront improve survival. And finally, we have an ongoing randomized trial that I'm leading called Golden Gate 360 trial, where we're addressing blina upfront as a consolidation and maintenance in older patients and younger unfit. And this will be another confirmatory trial for blina upfront.
You still do intrathecal in pH negative?
Yes, here the issue. When we walk away from chemotherapy, Chadi, these drugs do not cross the barrier. And we were concerned about CNS relapses. Therefore, we're giving more intrathecal to this patient to hopefully overcome the problem of lack of systemic chemotherapy. And that is happening right now. And for patients who are relapsing on this approach, we're using CAR-T as a consolidation.
Ellie, I think probably there's nothing more in heme malignancies that gets scrutinized and criticized more than MRD.
Correct.
I say that because people will argue there's no standard how to interpret MRD. The cutoff keeps changing because we have high sensitive assays. And the biggest criticism is nobody argues about the prognostic value of MRD. We all know that MRD positive disease go and predict progression. What the argument is, early therapy and intensified therapy may not be needed to achieve MRD positivity because you could burn bridges by doing so, and sometimes should just do clinical remission and just monitor patients. How do we resolve this fight?
Okay, Chadi, in acute leukemia, in ALL, there's nothing called minimal. One cell is already too much. So for me, there's no minimal. If you're seeing minimal disease or one cell, that means you're not relapse. And you better intervene at this time because you can get better return than wait for relapse. In fact, we've shown if you intervene at MRD, you can have a survival of 36 months. If you intervene at a full disease relapse, when you monitor by blood and you relapse, 12 months survival. So therefore, you must intervene at a very low level. No, you said it clearly. If your MRD positive is bad, we know that. But are we sure MRD negative are safe haven? That's why the test is very important. So flow studies get you a 10 to minus 4. PCR get you a 10 to minus 5. But NGS, what we're using today, is get you 10 to minus 6 and below that. At this stage, for example, if you have one cell positive in NGS, you are going to relapse. And
No,
therefore,
but nobody is arguing that you are going to
no,
relapse.
but then my second point is you need to intervene.
But why? Because what if
Because you're going to relapse otherwise, and
but
your
you
outcome
don't
at the
know,
time of, if you intervene and relapse, the outcome is worse.
but you don't know how long it's going to take you to relapse, right?
I know how to relapse. If you look at MRD, if you're MRD positive, time to relapse is 3 months.
Really?
Yes.
Okay, well that's different. It's probably
But
maybe
if your CLL and multiple myeloma may be different, but in acute leukemias, if your MRD positive relapse is imminent,
that's a that
you intervene or you let it go. I will intervene.
that is a good point. I like I said, I know relapse is imminent. The argument that you hear, and I kind of sympathize with it, is that the time from MRD positivity until clinical relapse potentially could be too long that you could wait until new therapy emerges, something new could happen.
No, if I have somebody who's MRD positive at a very minimal level, for me, I have to intervene.
Okay. In the last couple of minutes before I let you go, I know you have a hard stop, you have other meetings. What's on the horizon? New therapies for ALL? Like, is there what's exciting you about what's coming down the pike for the few patients now? I can't believe we're saying this, but I'm happy we're able to say this for the few patients who are not really responding. I think we know about CAR T. I don't know. Tell us about maybe some CAR T, bispecifics, or anything else.
You know, multiple ideas and multiple thoughts. Definitely MRD, we discussed it, and you have to get MRD to improve the outcome. That is given. I think we're shortening the chemotherapy, and that's good. But CAR T, where is the role of the CAR T? When do we intervene with the CAR T? I think the approval of the CAR T is in multiple refractory patients. I think CAR T should be used earlier than later, should be used at an MRD level or even a frontline, because if you use MRD really early on, if you use CAR T really early on, you can maybe cure these patients. Going from using a sequential approach like Blina, I know CAR T and transplant can have a bad survival. But if CAR T is being used upfront in minimal disease, you have a chance of a cure. I think the treatment of ALL is not anymore 2 or 3 years. It's 6 to 7 months, where we can take patients, we give them a cocktail of antibodies, be it CD22, CD20, CD19, okay? And then you induce a deep molecular response. And then you do CAR T consolidation where CAR T replaces transplant. So we're going from giving 2 or 3 years of therapy and relapse to giving short block of therapy with dose density, with giving all the best drug up front, have an MRD negativity, have CAR T cells, and cure this patient. I think this is the future.
Amazing. I think the progress that you guys have done in the ALL community has really been amazing. So congratulations to everything you guys have done.
Thank you, Chadi.
Anything else you want to share with listeners about ALL?
I want to share with my listeners today, you know, I'm very fortunate to live at a time where the cure of the disease is happening. Imagine, I'm living, Chadi, in a time right now, you and me. We can tell our children we cure this disease in our lifetime. I'm so optimistic. We have so many things, so revolutionary, changed the whole thing of ALL. It's happening in our lifetime. No more intensive chemotherapy, short chemotherapy, integration of immunotherapy up front, and a cure of this disease. I'm very
well, get ready, because remember, I'm going to see you live in the first annual Hemonc Pulse in Chicago, where, by the way, you're going to have to come up with some unanswered questions in ALL and AML. So
I look forward very much. Thank you for inviting me.
Dr. Elias Jabbour, MD Anderson Cancer Center, thank you so much for coming on the Hemonc Pulse.
Thank you, Shadi.